Hi guys, this is Dr. T, and once again, welcome to Clinical Medicine with Dr. T. So guys, if you are joining us for the first time, please consider subscribing to our channel and help us grow. So what I wanted to talk about in this video is shock. Shock is one of those topics that you look at them and you say, boring. And as much as it's boring, but many people have died because of shock. Many people have died because of shock. And I think the day you lose a patient as a result of shock, that's when you will see that shock is actually very, very dangerous. And shock is one of those things that can be prevented. I mean, shock can be prevented. It's very reversible, but it does get to a stage where it's no longer reversible. The patient complicates and actually dies. And if you sit and attend M&M's, mortality and morbidity meetings, and then you hear people commenting, and then actually when you sit, you're like, actually this patient died because of shock. It's not something that is easy to actually accept. Someone who dies because of shock. Yes, there are patients that will come in so sick that you won't even realize that they actually have shock, or maybe you'll be looking at a more potent kind of a disease or managing that, and actually not paying attention that actually they also have shock. There's also have shock that is going on, and when you are managing the actual sickness that they have or the other sickness that they have, because it's not impossible to be treating one condition and have another that will cause shock, and then the patient actually dies. So yeah, it's one of those things. Shock, it's very, as a medical student, when you're sitting there and studying shock, the causes, everything, what is shock, the causes, management, it's easy to do it, but it actually challenging when you are seeing a patient, because I think the issue with shock, if you don't anticipate it, it's gonna get you. You need to just anticipate that this patient that I'm seeing might have shock. Then when you actually go and check, oh, they actually do have shock. And we are going to talk about the things that you can use to determine if someone is in shock or not, because yeah, looking at the vitals is not sufficient. Okay. So things do happen in medicine, but I pray that I never lose a patient just because of shock. That would be something that I would actually take time to get over, because it's something that can really be managed, be treated, and if you anticipate it and you pick it up, you can actually go on and do something about it. Okay, so shock. I always try to run away from textbook definitions, guys. As long as we understand what we're talking about, it's sufficient enough. And there is no one in clinical medicine who's going to ask you, can you define shock for us? If they ask you to define shock, it means that your exam is not going well. It means that they've picked that you maybe don't understand what you're talking about, but they will hardly ask you to define shock. Yeah, and also, even if you try and define it, if you define it and you are right, you don't have to use textbook definitions to define it, as long as you understand what you're saying and you can actually find words to describe what you're saying. It's fine. So shock is a circulatory problem. Circulatory failure. So there's a problem with blood circulation, and this blood circulation, the way it's happening, it's progressing to hypoperfusion of our organs. Hypoperfusion of organs and tissues. And we know that for our organs to remain healthy and to keep us healthy, they need their blood supply. And in that blood supply, there are vital things there, like oxygen, like nutrients, that are very important. So if you've got a problem with your blood circulation, it means that we are going to have an issue with organ perfusion. And what are these organs that we're talking about? The brain needs oxygen and glucose. The heart needs oxygen and glucose. Your kidneys, your bowel, your liver, and etc. These are the organs that we are worried about. Because now, once you've got a circulation problem that affects these, and these guys, they pick it up that we're not receiving blood the way we are supposed to, they will get sick. And they will show. So they will be hypoperfused. And once the hypoperfusion goes on for long enough, you're gonna get organ dysfunction. Imagine if you get a dysfunctional kidney, if you get a dysfunctional liver, if you get a dysfunctional brain or dysfunctional heart, problems are gonna flood in. And if that organ dysfunction goes on for long enough, they get into organ failure. And once you get into organ failure, this is an ICU patient right now, and coma can happen and death will result. So shock is not innocent. It might be boring to read about it. It might be boring to actually sit down and read shock. But the day you lose a patient from shock, it won't be a nice day at all. So what are the types of shock? There are 4 types of shock, right? The first one, let's say hypovolemic. Hypovolemic shock. Hypovolemic shock has got 2 types. It can be hemorrhagic or non-hemorrhagic. Or non-hemorrhagic. So basically what we are saying here is that a person can hypovolemic shock is just a depletion, severe depletion of intravascular fluid. intravascular, was it blood volume? Let's say blood volume. So you've got hypovolemia. So you've got a depleted intravascular volume. That depletion of the intravascular volume can be from hemorrhage. Maybe you bled, gunshot, stab, that kind of a thing. And hemorrhage can be external or internal. So the fact that you have someone who's got a hypovolemic shock from an accident, you don't see any blood, it could be that they are bleeding inside the thorax or in the abdomen. So, or you can have someone who's got hypovolemic shock. So this would be your trauma, right? Trauma, hemorrhage. They will be okay. This would be your trauma. It can even be things like ruptured peptic ulcer disease. It could be things like ectopic pregnancy. It could be things like a ruptured aneurysm. So things like that. So let's not confine hemorrhagic shock only to trauma. There are other things that can result in hemorrhage that are not necessarily traumatic. And then non-hemorrhagic is usually your GIT losses, vomiting, diarrhea. It can also be kidney problems or adrenal problems, where a person is just, even diuretics like tablets that will make you to pee a lot and things like that. That's fine. So, and then the other type of shock would be cardiogenic. Cardiogenic shock is a reduced cardiac output secondary to intracardiac causes. Intracardiac causes, and these intracardiac causes can range from the myocardium. They can be valvular, they can be coronary, they can be just about anything, guys. So things like heart failure would be there, cardiogenic shock. And then also obstructive shock. The most common one would be tension pneumothorax. Tension pneumothorax. And the other, and even PE can, anything that can obstruct can cause even cardiac tamponade, right? Some say cardiac tamponade. Cardiac tamponade, things like that. So basically, it can be anything that can affect the proper feeling of the heart, or anything that is obstructing, that impairs the contractility, causing an obstruction, or anything that can obstruct the vessels, like your superior vena cava, inferior vena cava, lesions there can cause that. And then there's this big one, distributive shock. Distributive shock. So distributive shock has got different types. The main thing there is is a vasodilation, like massive vasodilation. This is the main problem here. Remember the formula: BP is equals to cardiac output multiplied by peripheral resistance. Once you've got anything that causes a severely reduced peripheral resistance, it's gonna drop your PR, and once your PR is severely dropped, remember, whatever that drops the PR will drop the blood pressure, whatever that drops the cardiac output will drop the blood pressure according to this mathematical formula. So with distributive shock, you have systemic vasodilation. You've got systemic vasodilation, and once you've got systemic vasodilation, you affect your blood pressure. And remember, your organs, they depend on the MAP for their perfusion. And once you decrease your blood pressure so much, your MAP is going to start to be affected because it depends on the blood pressure. And now you're going to get hypoperfusion of your vital organs. So the causes there under distributive shock is sepsis, septic shock, is anaphylaxis, or anaphylactic shock, things like neurogenic shock. I'm not sure if I'm missing any. So guys, so these are the types of shock that we need to always. The important thing, in order for you to anticipate that your patient might go into shock, you need to understand each and every type, and then you must understand what conditions, not necessarily medical conditions, what conditions can give you shock, what conditions can give you what, and what type of shock are you okay. So what type of a shock are you English guys, what type of a shock are you expecting depending on the condition that you have? Like for instance, on a patient who has been vomiting for a very long time, diarrhea, when I see them, I want to make sure they're not in shock. They might be dehydrated but not in shock, right? So that a kind of a shock that I expect there is hypovolemia. But now if someone comes in, they are very sick, they've got a high temperature, they've got an abscess somewhere, the type of shock that I expect there is septic shock, which is a type of a distributive shock. If someone has taken has been bitten by bees, or has taken red meat that gives them allergic reactions, or they've taken a drug that they're allergic to, a type of shock that I expect there. So when I get there, I need to know, are they in shock or not? The type of shock that I expect from them is anaphylaxis. So someone who is just taking penicillin injection, when they drop down because of hypotension, they are likely to be having anaphylactic shock. Someone who has been in an MVA and then now they've got weakness of the limbs and then they are in shock, it could be that they are in neurogenic shock. So it means now you must be able to apply in your this kind of information to all your patients and say, okay, if I've got someone who's got heart failure and I get there, they've got a blood pressure of 60/30 and a pulse of 135, 140. The shock that they have there is cardiogenic, right? Yeah, so let's meet in part 2 of this. Thank you so much for watching.